my portfolio covers cancer, social prescribing, personalised care, and quite a few other things, but they're probably the most relevant to today. So I just wanted to introduce Dr. Hassan Tahir, who's on the call here. He's the primary care clinical lead for personalised care with the Northern Cancer Alliance, and is also a GP in Stockton. And I won't go into, I don't think I need to go into cancer care reviews so much. I'm sure Hassan, you'll want to go into that, but I just wanted to comment really, I guess. Personalised care has moved on a lot over the last couple of years, particularly with, you know, the kinds of roles that we've got on the call today. And I think it doesn't necessarily, I think when we talk about personalised care, I think it kind of sometimes gets looked at very separately from other things. So it's just about joining it up and looking at how we can do things differently. But I'll hand over straight to you, Hassan.
Thank you very much, Tara, and really echo what Tara said. Some of the conversations Tara and I were having a couple of years ago when I first started my role are very much along the lines of personalised care, and it's great to see how things have moved on. However, one of the things I do get frustrated about a lot is that personalised care almost gets pushed to the bottom of lots of agendas. You know, it should be something that's done as routine practice for everybody, something that we all should be getting. So it's one of my things. It's not just a nice thing to do. It should be the thing that we should be doing. So what I'm going to just talk about today is about personalised care, specifically in cancer, but specifically about cancer care reviews, and a little bit about cancer care coordinators. Now, this is a really quite broad, extensive topic. I've tried to make it as inclusive as possible, and it'll be around about half an hour going through the presentation, and then some time to have a discussion. I thought that might generate a lot of questions, a lot of open discussion amongst the group, and kind of help lead the conversation that way. But also, I'm open to doing any further topics, or if anyone wants to have a chat at any other time, I'll put my email in the address box, in the text box, and you just drop me an email. So what I'll do is I will share my screen. I'm not sure I'll still be able to see everybody when I've got the presentation on, so just shout out if it's okay. Can everyone see that okay? I'll put the presentation mode.
Yes, yeah.
That's brilliant. Brilliant. So, like I said, my name's Hassan. I'm the personalised care lead for the Northern Cancer Alliance, predominantly for primary care, and I'm also the clinical advisor for Macmillan Cancer Support for the North East and Yorkshire. So the two roles kind of go hand in hand, and I do get to, there's a lot of overlap and a lot of work that I do, a lot of learning that we get in other regions that I can bring to our region and vice versa. So I'm going to go over some information about cancer care reviews first, and I'm sorry if a lot of this stuff might be already known to everybody, but for a lot of our colleagues that are new to the role, I guess it's a good introduction. So half of the people born after 1960 will get cancer in their lifetime, and when I was studying at uni, it's around 1 in 3. So the number and the incidence of cancer is only going in one direction, unfortunately. Around 70% of people with cancer have got at least one of the long-term conditions, be that diabetes, COPD, heart disease, and areas like ours where there's a lot of deprivation. The same risk factors for cancer will be the risk factors for those conditions, well, be that smoking, be it obesity, lack of exercise. Also, just because most people are living longer with cancer doesn't necessarily mean that living in good health. So after you go through your period of treatment, many people bounce in and out of hospital, lots of mental health issues to do with the recurrence of cancer, and many physical symptoms as well that can come, that can often be put down to cancer or not. So we know that patients don't live well with cancer, even though they're living longer. So there's a case for actually changing the role for primary care within cancer. So most people think of cancer as lots of hospital appointments, really, really busy, but the patients spend most of their life in primary care, even after the cancer diagnosis. So there's specific roles for when primary care can be really helpful for patients. So when they're diagnosed, or when the first part of active treatment comes to an end, when they're discharged from hospital, or if they're unfortunate enough that the cancer comes back, or also they're unfortunate again that they reach the terminal phase of the illness. These are all periods or elements of of care, that primary care can be there at the forefront and really be there for patients. And patients often talk about this black hole syndrome at the end of secondary care treatment, where they just feel like the contact just tails off. And this is something that we see a lot in evaluations from patients. These are some evaluation key sort of issues are identified by GPs when evaluations are being done, predominantly about the lack of guidance and structure from QOF as to what should go into a cancer care review, lack of training in cancer care about what happens in treatment, medication, managing symptoms. And it's such a fast-moving topic as cancer that what you learn one year might be irrelevant in a couple of years' time based on certain treatments. There's huge challenges of where to signpost people into community. And as a GP, I really struggle to keep up to date with what the voluntary organisations are and who you can refer into. Some people thought that the cancer care reviews were happening too early. This was around 6 months. There's a lot of pressure on GPs and primary care at the moment, and always has been, right, which means that a lot of cancer care reviews are just opportunistic rather than being dedicated appointments. And there's an expectation that when the cancer care reviews were at 6 months, that actually they were still being supported a lot by acute teams. So what really was the role for primary care at that point if they're still having a lot? So these are some of the patient quotes that patients just thought the GP just asked if they were okay. That's pretty much it. Some of the GPs would look back in patient notes and say, well, yeah, they've been seen the last few months, I'll just tick that review was done. One of the GPs said, you want a Lamborghini service, only willing to pay for a Fiat. You know, the extent of what cancer care review could be and how few points you get within QOF means that the priority for cancer within primary care is quite different. So lots of cancer care reviews were done over the phone and patients weren't aware of what they were for. They weren't given dedicated appointment slots. They're very opportunistic. And we start to see that regular themes start to occur. And a lot of these were from multiple different areas had run an evaluation. We tried to collate a lot of this information together. However, there is an evidence review that was published in the Journal of Cancer Survivorship only last year. And this was the first sort of real place where a lot of this information was collated and put together. And what they found, that a lot of primary care professionals felt that cancer care reviews were a tick box exercise. They didn't really have enough adequate time to deliver the cancer care review. They thought it was compounded by inadequate primary secondary care coordination, lack of communication, and very few patients could recall actually having a cancer care review. However, those that could recall it found it useful, but the biggest area for biggest group of people that found it most useful were the carers for patients with cancer. They found them the most useful, which is kind of, you'd hope that the patients with cancer would get it, but at least we're starting to see some carers come through. And this was relatively recent. It was only last year. So very quickly, I'm just going to go through what led to the current changes and why QOF is as it is at the moment. So in 2019, when I first started my role with the Cancer Alliance, the cancer care reviews were done 6 months after a cancer diagnosis, and what we found at that point was that in the NCPES there was a feeling that not everything was done by general practice during the treatment, but what that actually means was uncertain. What the patients feel by the GPs do everything they could to support the patient during treatment. It's very, very broad topic. Well, if we break down how cancer care reviews were done in 2019, now this is pre-COVID, the number of cancer care reviews done as a percentage were relatively okay in England and the North East. We're looking at 68 to 69% regionally and nationally. And this was a breakdown of CCGs for where we were at. We look at Northumberland sitting there around 67, just at or around the national average. Now, this was the last time we were able to get data done at a CCG level. And after that, it's moved over to PCN and ICB. And the NCPES in 2021, one of the specific questions they asked was, did the patient receive a review of cancer care by the GP practice? And the scoring here was relatively low at 20%. And I don't know whether this was the way that the question was loaded, or have you had a review of a cancer care, and why they didn't say, have you had a cancer care review? But this was around COVID time, and the QOF was put on hold at this point. So there's a feeling that maybe that had something to do with it. But overall, there's a lot of work that could be done in terms of, did they get the right amount of support during the treatment phase. So there was a lot of lobbying happened with the government, and there was a consultation went out, and we put a lot of information forward and argued for changing the way that cancer care reviews happened. And now the current QOF, what QOF says at the moment is that there's 2 reviews that should happen. The first is CAN 005, which is patients within 3 months of a diagnosis have a discussion with somebody from primary care about what support's available within primary care. And CAN 004 is that the patients who have had a cancer care review using a structured template occurring within 12 months of the diagnosis. So again, these were there to bring it to kind of deal with some of the issues that have been raised in a lot of the other evaluations. So we'll do a quick schematic. It shows that when a patient had the diagnosis, they get put on the cancer register. During treatment, they have this discussion of support with primary care, and in theory, they come to the end of the treatment, an end of cancer treatment summary, which is like gold dust at the moment. If you ever come across one, that's to be done at the end of treatment, and that document is there to help guide and help with the cancer care review that should happen around about 9 to 12 months after treatment. So this is in theory what the ideal model should look like, but in reality this doesn't always happen for lots of different reasons. Treatment may be longer, somebody may not come, lots of different reasons. To mention, these changes have come in place because we want to increase the actual personalisation of cancer care and the timing of it. So the CAN 05, it gives them a chance to actually have a discussion about what's available in primary care. Not all patients want it. It's the opportunity to have that discussion. And not everybody at this stage within 3 months wants any input from their GP surgery. It's a great opportunity for us to tell patients what's expected of us, what they can expect, and what sort of a support is available if they need it. And the CAN 04 is a much more detailed, structured review that goes on about the ongoing support and information that may be needed for patients, and that can be done any time after diagnosis, but it has to be within 12 months. And at the moment, we're seeing a lot of confusion from practices who are actually coding both these cancer care reviews together at the same time, but they are meant to be two distinct, separate reviews. So these changes have been in place for the last a year or so now. So it's quite interesting to see where are we now compared to where we were before. So if we compare the NC pairs for the support from your general practice, we can see roughly around about the same for how often they spoke to primary care before they got the diagnosis, and whether the diagnosis was explained the way they could understand, roughly around about the same. There is some improvement in the in Q3, but roughly around about the same. But the most important one for me is the care from the GP practice after diagnosis. So did you receive the right amount of support from your practice, and did you have the review? And you can see they've both gone up slightly there. Now the question 52, which is of most interest to me, has gone up to from 20 to 25%. So this still shows there's a huge disconnect there between what patients believe is a review of their cancer care. Now, the NHS average was 21%, I think, and our average for our ICB was 22%. So it was 25%. So yes, we're above the national UK average, but this tells us that this isn't just an issue for us in the North East. It's an issue across the whole country of why is it patients feel that there's a disconnect between what they feel is a cancer care review and the GP have got it. Have. And if we look at QOF for the end of year in 2023, we can see a lot of the practice how highly they've scored on cancer. So the coding is there. The NHS Digital, we were able to extract the data that these cancer care reviews have happened. And if we look generally across our region in the north, everyone sits at least 80% or above. Majority of practices sitting at 100%. So there is this disconnect between what we as clinicians feel we're offering patients and delivering to patients, and what patients feel that they are getting, and how they feel about that. So there's something that we need to do to try to bring those two together, and this has predominantly been a lot of what my work has been over the last couple of months, looking at what we can do in order to break down that barrier. So there's two elements of this. One is the resources that we've got from the Northern Cancer Alliance, and the other is from a Macmillan point of view, and I'll go over them both very quickly. So from the Northern Cancer Alliance point of view, we've updated the website. We're trying to build a much more interactive toolkit that patients are able to access. We've developed letters that patients can download and use, and they can embed them into their system within EMIS or System 1 to send out to patients, as well as providing access to the cancer care review template through Macmillan within both systems, and support for social prescribers as well. So you may already have seen this on the website. So this is the process that we put together within the system, and we wanted to make it more of a process driven, so that a lot of the stuff that we think the resources can be used can be done through back office admin, of our cancer care coordinator that doesn't involve a clinician at every point. So if you think of Cancer 005, as soon as a diagnosis is received, we should be sending these letters out, which involve a local support leaflet, the letter from which I'm going to show you shortly, which explains to the patient that we understand they've had a diagnosis and what they can expect. And the other part for Cancer 004 is that system recalls get added out. Information can get sent out to patient ahead of the time using Accurix, using Florries, or even using letters for patients from this concerns checklist, booking appointments, and then the cancer care review can happen. So a lot of this is a process cascade, which if practices can get this right, then a lot of this can happen in the back office away from patients. Now, as a gold standard, we always advise and we always push clinicians to telephone patients for something like a cancer diagnosis, to kind of close that loop and continue that relationship that they have with patients. Although that's not part of the of QOF or anything like that. So this is a new diagnosis letter that you can download from the website. It can be amended, so you can add in the details of a local cancer care coordinator, a phone number for your practice or anything like that. And because it's embedded within your system, it'll automatically pull the information for the patient, all the details, and it's mail merged, gets printed off and can get sent out to the patient at the time of diagnosis, and also be emailed out to patients. So you can make amendments to it or add local support service leaflets and things like that. And this can get sent out. This letter in itself is suitable and would tick off the Cancer 005 requirement for QOF, because it gives patients the opportunity to have the discussion. Now, many patients at that stage may not take up that opportunity to have it. Many will. And we're seeing a shift now from leaving up to patients to contact the surgery for this discussion to actually some practices and PCNs have got cancer care coordinators that are actively contacting every single patient, regardless of sending a letter out and making that contact. And again, that ticks the Cancer 005 discussion box as well. So there's a lot of different resources out there that are available that will help us engage with patients and to let them know that primary care is open and what we're there for. When we saw those NCPES results last year, I felt there was quite a big disconnect between what patients thought they would get from primary care and what they do get. So we put together a leaflet like this, which again can be downloaded, that we should send out to patients at the time of diagnosis, which talks of what a cancer care review is, what they can expect, how it will help them, and what additional roles and people that they will see within cancer care in primary care. And we felt that often patients don't know what to expect from a cancer care review. They don't know what it is. They don't know when they're going to have it. And you could argue, is this something that should be told to patients at the time of diagnosis? Should it come from secondary care? But just going back to patients and going back to our patient forums, it was felt that this was received from their own GP surgery, then it kind of holds a lot more weight that it's my own surgery sending this sort of leaflet out. They're the people I'm going to be having my cancer care reviews with. So that's where we've kept it. And again, this can be downloaded. And you can send this out for with patients to their leaflets. The other thing we've done is put together a cancer care review animation, which has only just been finalised this last week. So if it's okay, it's about a 2-minute animation. You guys will be the first cohort of people that are going to see this to have a look. So if it's okay, I'm just going to play this video and so you guys can see. Just bear with me 1 second. Just bringing it now. Is the sound coming through there? Yeah.
The way we look after people with cancer is changing. After your cancer diagnosis, you may have lots of appointments and support from the hospital. However, your GP surgery is also there to help. New roles called cancer care coordinators might be your main contact and could help you get information and any support that you need. This new group of people, who are part of the GP team, focus on your non-medical needs. You may have spoken to them when you were first referred to the hospital. Within 3 months of your diagnosis, your GP surgery will offer you the opportunity to have a discussion about the support that's available to you. This discussion may be with your GP, a practice nurse, or a cancer care coordinator. Because not everyone with cancer has the same needs and requirements, you'll be able to discuss what matters to you and to develop a care plan that's right for you. They'll support you with any aspects of your life that are affected by cancer and may put you in touch with other organisations who can help you. Your hospital team will keep in touch with your GP team and update them on your treatments. When you've finished your treatment, both you and your GP surgery will receive an end of treatment summary, which will help with your cancer care reviews. Within 12 months of receiving your cancer diagnosis, you'll be invited to have a dedicated cancer care review appointment with your GP team. This could be with your GP or a practice nurse. You may also be supported by your cancer care coordinator. However, you can talk to your GP team at any time about your worries and anything that's bothering you. The review will cover your medical and cancer experience, and will also give you a chance to talk about your wider worries and concerns. The review is not just about medical care, but can range from work and money issues to your mental health and well-being. It's an opportunity to bring together what's happened since your diagnosis and to talk about how your GP team can support you in the future. Your GP team are with you every step of the way, helping to build up confidence and resilience in living with and beyond cancer.
So that's an animation that forms a series of different personalised care animations that we put together. Most of them have been about treatment summaries and personalised care involving stratified follow-up in secondary care. But we're following that series along to include primary care as well. I'll just go back to share the presentation. So these are all the resources that are available on the website, and the animation will be available on there as well for you to share with patients. And the hope is that it increases the understanding of what the role of cancer care reviews are in primary care, to try and help sort of break that barrier between the disconnect between what we feel we're doing and what patients are getting. These are the concerns checklists that they can be downloaded and sent out to patients ahead of their cancer care reviews. Essentially, they're there to help guide the discussion and guide the conversation for patients to discuss what sort of concerns that they're having. And this is an example of a cancer care review invite letter that you can use to send that information out. Again, these can all be embedded within EMIS, within System 1, can be changed and tweaked to be more personal to your own GP surgery. And this information is all available on our Cancer Alliance website and on the Macmillan website, which we're going to go over just shortly. And all these resources are available there, available to be downloaded. But if there's any problems with any of them or any links that don't work, do get back in touch and let me know. But we are working on a much more interactive and much more accessible toolkit. From a Macmillan point of view, there's also a lot of work that we're doing from cancer care reviews and cancer support for patients post-diagnosis. And one of the big things that we're doing is been working along with Accurix. So I'm not sure whether everybody uses AccuRx. I know during the pandemic, all practices had access to it, but over recent times, it's been up to PCNs to make a decision as to whether they want to continue that on. What we did at Macmillan was create this Florey, which is a questionnaire that gets sent out to patients on the phone via SMS text message, and they can fill out the questions or answer the questions on their phone. And you may have seen these that practices are using for things like pill checks, COPD reviews, asthma reviews, for example. And this one's in collaboration with Macmillan. And these are just some screenshots that I took from my own phone of what it looks like when it comes in. So it asks what treatment you're having, whether you're getting any symptoms or any other issues that you wish to discuss along the way. Really easy to use, just touch buttons and you can type in any sort of free text that you want. Any other sort of things that are bothering you, talks about anxiety, about worries about the future, about finance, about smoking, and then about sleep, about activity. So that they're already preset questions. We can't amend what the questions are, but these are sort of preset questions that get sent out to patients. And then once it's been complete online, it automatically comes to accurates into the GP system, and this is what it comes back at you as. So there's information that gets sent to you before you actually conduct your cancer care review, which has already got a lot of information from patients for what might guide your discussion. Now, again, this involves patients being engaged with what this is, and if a message like this just drops into their inbox on the phone, they may not know what it is that they're waiting for or what it is that they're doing. So those discussions to be had at 3 months really does set the groundwork and the foundation for ongoing sort of cancer care for patients in the community. So can't stress enough how important that initial conversation is to kind of let patients know what it is to expect. At Macmillan, we've also got the 10 top tips for cancer care reviews as well. So these are, again, fit a series of top 10 tips that we do with Macmillan. This one's about cancer care reviews, but there's one for social prescribers as well. And it really just goes through different things that you could do to help get the most out of the cancer care review itself. And again, available on the on the cancer care review website at Macmillan. There's an e-learning module that we've put together as well. It takes from about 45 minutes to an hour. And this is Anthony Cunliffe, who's our national clinical lead for Macmillan. And it's an e-learning module that goes through the different facets and elements of a cancer care review, involving the clinical, the non-clinical medication reviews, for example. And it really kind of helps you, give you the tools to have that discussion with patients and kind of what to expect and how to guide that conversation along. Very few people who do cancer care reviews have actually had any dedicated or specific learning or sort of education based on what should be in a cancer care review. So this is one of the ways in which we're trying to overcome those barriers, to have a set of modules that we can get all clinicians to do. Then it kind of improves the quality and ensure that regardless of which practice you're at, this is a standard of cancer care review that we can expect. Now, to access this learning, you do have to register on the Macmillan website, but you do have, once you register, you do have access to a wealth of other resources as well within Macmillan. It's completely free to use, so I would really encourage everybody to sign up and do the module. It takes around about 45 minutes. As I mentioned, it goes through different elements and different topics of it. It goes through the different resources that are available and how to really get the best out of the different topics within there, such as a diagnosis, treatment consequences, medication reviews, patients' needs and physical activity. So it's a really, really good resource and a good e-learning module to do. Switch over that one. I'm going to very quickly just go over some stuff about cancer care coordinators. I know we've got a lot of cancer care coordinators who are new to post here on the call. So this is something that we've been pushing for quite some time to try to get locality groups, PCNs, to put cancer care coordinators in through the additional roles reimbursement scheme. And the thought was that there's multiple different areas through the cancer pathway within primary care where cancer care coordinators can provide a lot of support to patients. And
Hassan,
there's two sort of kind of...
Hassan, sorry, Suzanne, you couldn't just put your presentation back in presentation mode, could you? Because I'm struggling. I might not be the only one.
It was.
No, don't worry.
Presentation. Give me 1 second there.
Yeah.
1 second.
Brilliant. That's it. Perfect.
Sorry,
Thank
I didn't
you.
know it was
No, don't worry. It was only after the animation. Thank you.
Brilliant. So there's lots of different areas where cancer care coordinators can get in post. Now, just linking back to the animation, we have to be quite clear that there's a lot of variability at the moment for access to cancer care coordinators. Not every PCN, every GP surgery is going to have them in place. So it may not be relevant to everybody, but we're really pushing for the additional support that they can bring into patients, whether it's at the early part of the pathway for involving safety netting, providing additional support to get patients to their appointments, for patients missing appointments for whatever reason, not returning fit tests, that sort of thing. To the second part of the pathway where post-diagnosis, if they've got a diagnosis, what support do they need? If they don't have a diagnosis, then what symptoms do they still have that still need feeding back to the clinician to take to further investigation or further reviews, as well as if patients are on terminal phase, do they need to be put on palliative care register? So multiple different places where they can provide this additional support. And we have looked at other PCNs where we've tried to bring these into place, and some areas have had varying degrees of success, not just regionally, but nationally as well. So I've linked in with lots of different organisations and PCNs across the country and tried to work out why is it that they've not worked in other areas. And some of it comes from generally having quite poor support from clinical leads or from line management. They're not really sure of what their role should be. Many of them from non-clinical backgrounds, having really, really difficult conversations with patients, and patients think that they're speaking to a nurse or a doctor and expecting a different thing. There's a lack of training associated with them in the roles, going from non-cancer backgrounds and certainly expected to have these difficult conversations. There's sometimes overlap between primary and secondary care roles, and we get secondary care cancer care coordinators feeling as if they're already doing this. We're getting duplication of discussions had with patients. There's also a small pool of cancer care coordinators or care coordinators, full stop, and we saw a lot of moving around from cancer to care, home care coordinators to lots of different elements, and it led to really poor job satisfaction, and that meant we couldn't retain them. So some PCNs that started off on this process ended up winding it down because they couldn't recruit or couldn't retain their staff. One of the real success stories is in South Tyneside, which has been in operation since before, it's about March 22 now, so it's been just over 18 months. And again, it started off as a single GP practice, and it's now spread across the whole PCN. And they've taken on the two cohorts, the front end and the back end of the pathway, looking at the 2-week rules and the new diagnosis. What happens, an introductory phone call happens, post-diagnosis, explain the role of the cancer care coordinators and what they sending out a support pack explaining what can patients expect from them as they go through their cancer journey within primary care. They conduct that first initial review, having a very holistic discussion with patients, talking about the support. And when it comes to the second review, the cancer care coordinators are instrumental in collating all the information together, making the appointment, sending out the information, bringing it back, having that holistic discussion, bringing all of that together, packaged up, and then booking the appointments in with the GP in order to do the clinical side of it. When we looked at this and compared it to GP surgery in Gateshead and tried to evaluate the service, we found that there was the amount of time that patients got with a cancer care coordinator through this was upwards of an hour. Whereas when we compared it to the amount of time that you'd have for your cancer care with the GP, it was down to sort of 10 minutes, 15 minutes max. So the discussions that are going to be had over this time with a non-clinician in a non-clinical setting, patients really do open up. And we found that with Macmillan through projects called Improving the Cancer Journey. It was a big project up in Glasgow. So that's something that is on strategy for Macmillan to really push non-clinical cancer care coordinators out in the community to really get these conversations had with patients, to really get to the crux of what it is that patients want to have discussions about. And some of the comments that have come back from South Tyneside have been absolutely fantastic. And when we compared it to the NC pairs, these are reports about the impact and the service that they've actually had in South Tyneside. So they couldn't improve the service any more. Than a wonderful job. Very happy with the support and service. No complaints. And knowing the support was there if you need it. Everything was excellent. We've had some much more focused feedback from patients talking about not being able to have some of those conversations with GPs in the surgery, because sometimes you feel as if you're wasting people's time. You don't want, and you think it's much more clinical. Whereas these conversations you had with your cancer care coordinators are much more wide ranging, about finance, about health, about your worries. So it really does bring all that valuable information that we need to have a holistic personalised care assessment with patients. So from an alliance point of view, we are looking to aid practices and PCNs with structured implementation, be it the front end of the pathway or be it the back end of the pathway, both together, one then the other. But really it's up to the locality groups to decide how they want to go about it. Because the funding is available through ARS, through reimbursement, it's up to PCNs to decide whether that fits within their plans going forward, and how they want to implement that and how they want to take that forward. But from a Alliance point of view, I'm available to help with that implementation, any support that may be needed along the way. One of the things we did do was to create a core competency framework for cancer care coordinators. So it goes through a lot of e-learning modules through Macmillan we went through, but also trying to learn about QOF, learn about cancer care reviews, and building up that relationship with secondary care. So understanding the process of MDTs, so that you become that port of call for patients that sit within primary care, be that with secondary care, primary care, palliative care for the patient. So these sort of competencies, they're not going to happen overnight. They're going to take 6 months, 12 months, sometimes a little bit longer. with appropriate line management and clinical leadership. So what we want to do is create this a career pathway for yourselves, cancer care coordinators, coming into cancer and really enhancing and developing your skills, and really getting that fulfillment from the job. As I mentioned, at Macmillan, we've created 2 modules that are aimed specifically at social prescribers. So what we found was there's lots of people that were cancer care coordinator specific, but there are also many people that were social prescribers that had an element of cancer within their role. So we broke it down into 2 different modules, looking at cancer specifically, but also about what support and resources are available for patients to have those journeys. And as I mentioned, lots of e-learning modules that are available through the Macmillan Support website to help give people the skills to have those difficult conversations and understanding the needs of patients and services for people living with and beyond cancer. So I'm gonna stop there. I'm mindful that I've done a lot of talking over this presentation, and I wanted to open the floor up to everybody if there's any points of discussion or any questions anybody had that they wanted to develop, to go into any further detail or anything at all, really. So I'll open the floor, and please don't be shy.
Hassan, thank you very much. Thank you for that. Hassan, I just want to point out, so in Northumberland, we'll have a lot of care coordinators, but not specifically cancer care coordinators, though we do have a couple of care coordinators, I think, who have cancer support as part of their role. And I think a lot of, I mean, they'll be a bit, but I'm assuming some of the care coordinators on the call today will have some element of cancer support as part of their role, but I'm hoping that they still found that useful. But yeah, if anybody wants to ask any questions, feel free.
Yeah, we're finding that in a lot of PCNs, depending on what scale people are working at, so in some of the smaller PCNs, there may not be enough cancer work to have a dedicated cancer care coordinator. In some of the bigger PCNs, like in South Tyneside, they've got 3 specific cancer care coordinators and 1 senior sort of leadership cancer lead. So it depends on sort of what scale you're working at, really. But either way, these conversations that you have with patients, they're not easy conversations to have, and sometimes they do bring out a lot of information, and patients don't always want to know whether you're a cancer care coordinator, whether you're clinical, non-clinical. It's the GP practice, the surgery, the NHS wrapping their arms around patients. So I think it's really important to feel confident having those conversations. So if you can access those e-learning modules, they're really, really helpful. They're quite short to do, but they really can give you the confidence to have those really difficult conversations, not just in cancer, but with patients in other disease groups as well, because it'll be the similar skills that are transferable.
I think one of the things we wanted to ask as well, while we had everybody on the call, we were thinking about the other day that one of the elements, and you said it was really important, is that signposting for patients, and maybe also being able to refer the patient into the social prescribing service. So I just wondered if folk on the call today knew who their social prescribing teams were and felt they had good links with them, or if there was anything we could do to improve that. No, does anybody?
I've met mine. It was really nice. Sorry, I'm just butting in. My name's Freya. I'm from Frida Medical Group. Yeah, so we had a lovely meeting with the attached roles staff in our practice, which was great. Really liked the fact that my manager had done that, because we got to know each other. We also worked with some other services. I think it was like the healthy living services and how we could refer to them as well. So it was really interesting. I've got one link worker that works here, but I never really see her. And I know that I had a meeting, and the kind of a lady that she's the lead GP for cancer in West Northumberland, and she said, you know, we'd love for you to signpost more to the link workers. They don't actually have a lot of referrals going through, and I kind of wanted to know more about how I would signpost to them and what I could go to them for, because although I had a meeting, it was lovely, but it's I've kind of forgotten a little bit about what I could do with them and how we could work together. So I didn't know whether I should organise a meeting with my link worker again and try and talk to her about it, or how best we can complement each other.
Yeah, I think that's really, really helpful, Freya. And a lot of the resources or the people that you might signpost people into from the social prescribers, they're not necessarily cancer specific, but they don't need to be. A lot of the feedback we get from cancer patients that don't want to be ring fenced as cancer patients, and they want to be going to services where you're going to come across patients with other illnesses as well. But I think having that relationship with social prescribers or your health and wellbeing coaches, I think it's really, really important, because they're people that you're going to be signposting them on to, and they're going to move them on to other areas. So having those, if you're not sure what's available, it's having those conversation discussions with them. I don't know whether you guys all work very closely in one area, or whether you're all based within practice and you don't share offices with the social prescribers, but having regular sort of catch-ups to see what's current and what's available, and how they see you guys fitting in with them is going to be really, really going to help you along the way.
Does anybody have any more questions for Hassan? And Hassan, you'll be sharing the presentation, the slides, won't you? It's just, I think Sally asked in the comments if they could have the link to the Northern Cancer Alliance website.
Yes, yeah.
And that's where they can find those resources that you've been talking about
yes.
today, isn't it? Yes, right.
So what I'll do is I'll put it in the chat box as well just now.
Yeah. Heidi, did you have a question?
Yeah, hi. I'm a newly appointed care coordinator. Our reviews are done by our nurse practitioner. She does a lot of the cancer care reviews. I do the admin of trying to get them in and send the letters and things. So are you saying then that it doesn't have to be medical, more clinical, should I say, that myself as a care coordinator could take that work off her in any of the reviews? Or
I think especially in the first review that happens within 3 months doesn't necessarily need to be medical, because a lot of it is discussing what support is available within primary care, and sharing those resources, the animation, the leaflet with patients, so they know what to expect. But even with the second review that happens within 12 months, there does need to be a clinical element to it, because there are medication reviews that happen with it. But there's a huge amount of information that it can be collated before that. If we look at that concerns checklist, it talks about their fears, their worries. There's a whole wealth of information that they might find it easier to have that discussion with yourself, Heidi, in a different environment than what they would do with a nurse practitioner in their cancer care review appointment. And gaining all that information before the actual appointment, so it's ready for the clinician, it'll really guide that discussion and make it much more focused discussion. So I think having those processes in place would mean that there's a huge amount that you could do that's non-clinical. But again, it depends on the individual process within the practice, and more importantly, your confidence in having those conversations with patients as well, with the right support and line management and the right training. There's no reason why you can't do that, because we've seen that happening in other areas. Yeah.
And if I do a bit of the learning and the modules that you pointed out before, that would be a good starting point.
Absolutely, and there's a competency framework there which have different elements of their fit to kind of go and read up on, in order that you've got like a good breadth of knowledge around cancer, to give you the confidence and to give the clinicians confidence that you're having those discussions with patients as well.
Okay, that's great. Thank you.
Tara, did you have a question?
I did, but I'm happy to come in last if that's okay, because I think I don't want to kind of skew off to a slightly different thing. So I'll let Freya go first.
I don't know if I'm skewing off to another thing as well. But I really like the sound of the CCR invite letter. I thought that was fantastic. And it's nice that we can kind of mould it to our practice. Now, I'm not the best with technology. I'm not bad. I'd give myself about a 6 or a 7 out of 10. But if I want to implant it onto System 1, where do I find out how to do that? Or shall I just ask one of my secretaries?
Well, the secretaries will know, but also if you go onto the website, there's a section here which tells you how to embed it in, so that there is a a little section on there which tells you how to embed it in. I did put together a quick template of how to do it, but most secretaries will know it comes up as a document, as a Word document that you can download. Are you on EMIS or are you on System 1?
System 1.
So on System 1, so you can actually, within System 1, you can actually generate a letter using a template, and you can set it up so that it automatically pulls the patient's information, demographics on there. So if you have a chat with your secretary, that can do that with any sort of Word document or any sort of PDF document. But if you have any problems doing it, just go back to the website, and if not, then just drop me an email and I can have a chat with them as well.
And does the concerns checklist, is that like a holistic needs assessment? Is that what you'd sort of class it as?
So it's a type of holistic needs assessment. So
Right.
when patients are in secondary care, there's one of the marks that they have is a specific holistic needs assessment. Now, primary secondary care systems don't always talk to each other very well. So they may have they'll have a specific holistic needs assessment at the point of diagnosis. And this is a kind of a caveat to add on to that. So it has the same topics to discuss. There are certain platforms like the Macmillan EHNA one that you can access from primary and secondary care, but depending on your trust, they use different platforms like Somerset and whatnot. So what we don't want to do is to have too much duplication over having these concerns in EHNA. So it's always worth having a chat with patients and seeing whether they've filled one out. But that's essentially what it is. It's a form of holistic needs assessment. Yeah.
Lovely, thank you.
All right.
Like
yes, go on.
I guess I just wanted to ask, like all of you guys in these roles, how aware of local services in Northumberland are you? And I appreciate, you know, when your role's not a social prescribed link worker, that's not necessarily your bag. But there are a few different things, there's a couple of different platforms that are available for anyone to use, not necessarily just professionals, but patients can use them as well. And I think it doesn't necessarily all have to be about patients that, you know, speaking to a social prescribed link worker necessarily, if that's not something that they want to do. So I just thought I'd mention things like the cancer care map that's available online. And in Northumberland, we've also commissioned Northumberland Frontline, which is kind of quite led by the voluntary sector in Northumberland, and you can do it by postcode and topic and things like that. And we've got a patient group who have been working on kind of helping to build that in terms of cancer relevant services. And there's quite a range on there. So I imagine your link workers will already be aware of things like Northumberland Frontline, but you can make the awareness, you can raise that with your patients, because they can self-refer, or, you know, certainly Northumberland Frontline referrals can actually be made via that platform. It doesn't have to be via phone and things like that. So there's quite a few things out there that I just thought I'd mention just in case you weren't aware. And if you do want more information, myself and Suzanne can send you stuff about the local platforms that we've got available and things like that.
And often, it's not always, can't retain all this information at your fingertips. It's just knowing where to access it, isn't it? It's such a fast moving thing. There's always new things coming up and going. It's just knowing where to access it from, because the best world in the world is you can't keep all this information in there.
And Hassan, I think you made a really good point earlier around things being ring fenced, because actually if you know, the people in Northumberland who we're talking about now are aware of these different platforms where they can find information, because Northumberland Frontline is a generic social prescribing platform for anything in Northumberland. It's not cancer specific, so if they might already be aware of it for a financial issue or something like that, you know, once they're aware of it, they're empowered to, you know, look for this information for other things, not even just cancer related stuff. So I'm always really keen that we kind of look at that broader picture. But if you, like I say, if anyone's got any questions, or if anyone wants any training, anything like that, we can sort anything like that out.
That's brilliant.
Do I have any more questions? No. Oh, well, Hassan, thank you so much for coming along today and talking to
You're
everybody. I found it really useful, so I hope everybody else has. And I'll share, you're all right, Hassan, if I share your presentation with the
Absolutely,
group,
yes.
yeah. And
Yes.
I'll see where we can pop that recording on as well and share that with people who couldn't make it today.
Fabulous. Thank you very much for asking me along. Like I said, if you've had any questions or anything in the future, just drop me an email.
Lovely. Thank you, Hassan. And thanks everybody for attending.
Thank
Have
you.
a great day, everyone.
Bye.
Bye-bye.
Bye.
Thank you.